Good morning. Welcome back. Thank you to those of you who thank you to all of you here, the folks who hung in for day two. We're really excited to welcome you. My name's Heidi Brown. I'm one of the faculty on the D&I Launchpad. Please help yourself to refreshments, coffee, tea, etc. At the back of the room throughout as you need them. We are going to, this morning, for those of you who may not have been able to attend yesterday, the bathrooms are out through those doors and to the left and around the corner. Please use the facilities when you need them. I'm going to go through the agenda this morning and sort of refresh everyone about where we are. I want to remind you that there are Post-it notes on each table. So if something comes up for you that's an interesting question, jot it down while it's in your head. And then if there isn't time to address it during the session, pop it up on one of these boards and we'll address it during a session later today. What I'm going to start with right now is another brief acknowledgement of the land on which we're standing and sitting today. So UW is situated on traditional territories. The Ho-Chunk Nation calls this region home, and this place where we're meeting is known as Dijope. Villagers and their agricultural fields thrived along the banks of these lakes, along the Wisconsin Rock, Illinois, Fox, Baraboo, Trompereau, La Crosse, and Black Rivers, and all of their tributaries. After the War of 1812, the U.S., acting through a citizen paramilitary, removed Ho-Chunk people and resettled the area without the Ho-Chunk Nation's consent. The Black Hawk War of 1832 led to the 1832 and 1837 treaties signed for the land upon which this university is built, first ceding title to 6.8 million acres and then all of Ho-Chunk Nation's territory to the U.S. government. We want to give thanks to the Ho-Chunk Nation. And the other 11 Native nations whose territory now lies within the state of Wisconsin. We also extend our thanks to the plants and animals, the water and soil that form our greater community of life. We recognize the enduring presence and territorial claim of Aboriginal peoples on this land. I am excited to do a little recap of what we thought were the interesting and exciting things that came out of day one. And then we're going to hear again from our guest faculty member, Dr. Enola Proctor, on outcomes for equity and opportunities to utilize the implementation outcomes framework to reduce health disparities. We'll then have a brief break and we'll hear from our other distinguished guest faculty, Dr. Erin Lyon, about leveraging human-centered design to improve implementation and outcomes. After another brief break, we're going to do an emerging topic session, which tends to be one of the highlights of this short course, where we take a deeper dive into the things that we've talked about over the last couple of days. And during that point, our two guest faculty will address some of the questions that have emerged that have not been addressed yet and expand in whatever direction the folks in this room are motivated to expand in. At 11:30, we'll be adjourning. And please fill out the evaluation of this event. We actually changed the program. We put a lot of effort into modifying this program every year to meet the needs of the attendees. So it's always annoying to fill out another survey, but it really does. If you ask, you shall receive in the next short course. So please try to fill that out if you can. So a recap from day one. So last night after the table of D&I Launchpad faculty and our esteemed guests sort of talked about what we thought the key takeaways were. And we talked a lot about the thing and how the concept of the thing really resonated with a lot of attendees yesterday, the thing being the intervention, and the challenges of figuring out the thing what is the thing, and disentangling the thing from how to do the thing. So disentangling the intervention from the implementation strategies. We also talked about implementation outcomes as a way to sort of measure how well the intervention is reaching and performing in these domains that are important, but that we should also be applying those implementation outcomes to evaluation of our implementation strategies. So putting another layer of complexity and things to disentangle as we try to improve our science and expand the field. We also talked about the importance of understanding implementation outcomes from many different perspectives. You know, the perception of the elephant is different depending on what part of the elephant is being touched. And so it's really important, especially as we bring in these concept of user-centered design, to think about the perspectives of different types of users. And we sort of wanted to elevate Dr. Lyons' statement that if you're designing for everyone, you're designing for no one. And also, your user is not you. So understanding different perspectives and really clarifying who are you designing for? And with that undercurrent of health equity, thinking about designing for the folks who most need the intervention to be designed for them, as opposed to designing for the most resourced, which is a tension that we sort of fall into often in this type of work. Those were our sort of take homes. And finally, Dr. Proctor's comments about how things are always evolving and we're learning all the time. Our methods evolve, our outcomes evolve, our measurement strategies evolve. Even those of us who are experts are still learning just as much. So you're never really a beginner, or you're always kind of a beginner in this field as we do this very challenging and exciting work. With that, I'd like to welcome Enola Proctor back to the podium to talk to us about outcomes for equity, opportunities to utilize the implementation outcomes framework to reduce health disparities. And this is the opportunity for our visiting faculty to share with us the active initiatives that they're working on right now. Not as much sort of the overarching intro to the field and the way they think about things, which we got yesterday, but today is what they're doing today. So you are welcome to the cutting edge. Thank you, Dr. Proctor. Okay.
The clock is visible.
It is visible and Whitney's right there.
Okay, great. Good morning. I didn't do my mic. I'm sorry. Do we have the lavalier mics? Okay, great. Okay, is that better? Good morning again. Hope everybody got a good rest and is ready for another morning of thinking. And I was so excited about the opportunity to bring to the Launchpad some emerging ideas, some untested hypotheses, and some thoughts about important areas for moving forward with implementation science. So I'm going to focus on two today that I've been thinking about most recently. And one is, of course, the issue of equity. I don't think I've been to a conference where equity has not been at the forefront. it's an extremely important topic because I think inequity really signals that we haven't done a good job with implementation. We haven't reached huge pockets of people who could benefit from our interventions. And yet we have too little data for our work on equity. And so I've been thinking about some directions for research and some data that we need to gather. Also, the issue of timeliness, and I referenced yesterday my work with COVID mitigation policies, and that has loomed large in my thinking vis-a-vis the old adage that it takes 17 years. So this is some new thinking. The timeliness piece is reflected in a paper that I'll reference. The equity piece will be included in that revisiting implementation outcomes paper that I think is getting near submission. So think with me today about equity and timeliness and the contribution of implementation outcomes to these important goals. Now, this is a subset of the model that I presented yesterday, starting by saying, the used to be was a sole focus on patient outcomes in our effectiveness trials, our behavioral health trials, our medical trials, addressing the needs of children, older adults. And I don't want to ever lose sight of the fact that, that's the goal. That's the goalpost. We really want to improve human functioning, human health, be it at the individual, the community, or the public health level of analysis and the level of reach. Similarly, we are not going to be able to do that without some attention to service system outcomes. We need to be efficient, safe, effective, equitable, patient-centered, and we need to deliver timely care. So what I'm excited about this morning is an opportunity for us to think and for me to hear from you about how implementation outcomes might facilitate or failure to reach some implementation outcomes might slow or hinder us in achieving, in particular, timely delivery of care and equitable delivery of care. So once again, I'm always looking for signals in the invitations for research to help direct our energies towards some of these issues. And the most recent PAR, and for those of you, a PAR is I don't even know what program announcement, but it's inviting, it lays out what funders want from you. And it's important that you find a good balance. If you want external funding for your research, it's important that you find a good balance between the pressing questions at hand for your communities, your stakeholders, your care settings, and your own scientific interest. And then you got to find somebody who wants to pay for that. So reading and nuancing your grants to demonstrate their responsiveness to the message of what someone wants to pay for is important. So, I read these program announcements over and over and over, and they do change, sometimes in very slight ways, but in important ways, because the changes from one issuance to another really signal the direction that the funding institutes are moving in. And they're trying to advance the science, so they're going to kind of be tugging us in some new directions continuously. So in preparation for this talk, I reread the new program announcement and wanted to highlight some words that some of these were in the PAR 18, but they certainly were not in the program announcements previously. The new program announcement indicates that applications need to give adequate consideration and specification of the equity-related approach and outcomes. Now, you'll have to read it carefully to figure out I don't think that's every application. But if you are interested in equity, here's some guidance from the 19 centers and institutes that have signed on to the cross NIH program announcement or invitation for grant applications, that this is one of the ways they invite you to focus on equity-related approaches and outcomes. So those are opportunities to highlight and kind of put the marquee spotlight on those aspects of your application. Also, I related an anecdote yesterday about my dismay that the first 5 or 6 program announcements really didn't address the pace of implementation. And recent program announcements, the past 2, have included as an innovation feature. In other words, if you are studying this, you get some innovation points. How your study proposes and promises to speed translation of research. And that's the first, these past 2 program announcements are the first that I've seen that has the word speed in it. And I say I'm kind of surprised about that because we've heard about the 17-year gap, which has become our rallying cry, our in some circles the raison d'etre, the reason for being for implementation science is that we want to cut this time period. And this is particularly acute for researchers studying child health care and older adult health care, or people with rapidly advancing diseases. You know, we don't have 17 years to advance pediatric care. Those kids are going to be grown and they're going to be entering the adult systems of care where there's poor handoff, poor transition. And if you're dealing with an 80-year-old, you better figure out, we better have new discoveries sooner than 17 years if we're going to benefit that individual. So it has long seemed important to me that timeliness be tackled and that we go beyond the rallying cry for let's make sure we have equity and let's be worried about the 17 years. So what I'm sharing this morning are some of my thoughts that I invite you to think with me and for me to learn from you about some directions around these 2 important issues. So where is equity in the implementation framework? As I said earlier, it seems apparent that inequity signals an implementation failure. Now, I know that a lot of inequity, probably most inequity, resides in social determinants of health. We know that inequity is baked into our communities, our policies. They're hardwired in our policies. And they certainly disadvantage people from the get-go for exposures to environmental toxins, to psychosocial stressors, not just stressors, but traumatic events, adverse events. So we should not assume that as implementation researchers, and this may be controversial, but it seems to me that we're not going to be able to dismantle, eliminate inequities just through implementation science. We need health services research, we need policy analysis, we need environmental justice. So, there's a whole lot that we need in place to help us tackle inequity. But nonetheless, and that middle box of service system outcomes, I didn't make that up. I don't know whether I wish I did or am glad I didn't. Probably glad that I didn't. That comes from an old model from the Institute of Medicine that was a landmark report signaling directions in healthcare. And as I last searched, that had not been updated or modified. Let's see. You can watch my bottle full. Never mind. So equity is in that very basic framework that we published in 2009. I don't think it's received adequate attention, but that is one of those outcomes that the then Institute of Medicine, now National Academies, has called our attention to and directed us toward in reshaping healthcare. So, I showed that earlier slide of those 3 columns of outcomes with an arrow. Nothing is unidirectional. But the question is, how can achieving implementation outcomes advance equity? So one of the, we're going to have some interactive work later, and I want to hear from you, and I encouraged you to take home last night and be thinking about some examples. And I would like to pause my talk to hear from some of you a couple of ideas. Pick any implementation outcome that you wish. Think about how its attainment can advance equity, or how, if we don't attain it, we're at risk of perpetuating inequity. Can I have a couple of examples? Yes, great, Ed. Okay, I think we're going to need you to have the mic. Thank you.
I can project acceptability and appropriateness for whom? If it's acceptable and appropriate only for people who live in well-resourced, settings where they have access to high-quality academic medical centers and so on, and those are the people with whom we're verifying the acceptability and appropriateness. Then who are we designing for? That's an obvious.
Okay, that's a great example. Another thought? Yes.
So how do we make our adaptations not perpetuating of like inequities that have maybe existed historically or in other ways? For example, like when you're an implementation of a decision aid where you're helping patients understand their risk, and there are inequities in risk for diseases like lung cancer by race and gender, but some of those inequities are probably because of other. We don't want to perpetuate the inequity by saying your lifespan is too short to like for this tool to be of use to you. So I think we have to figure out how we're going to build in corrections. Corrections.
Yeah. Okay, and it may make it more appropriate. But we also want to make sure that the first part of your comment, I was thinking about adaptations that might erode the effectiveness. So, it's an interesting path to figure out how are we going to adapt the thing to make it more acceptable without making it less effective. I don't have the answer, but that's a challenge. Yes.
I have a very strong voice. So I'm trying. I watched this really good talk by Dr. Sydney Hankerson, who does work with Black and African Americans in New York. And I thought a lot about penetration because he was pulling his knowledge of mental health and his knowledge of mistrust in the medical system by Black youth in particular, that he was bringing mental health care into the churches and like mega churches in New York City. And I think a lot about how that was really listening to like how to actually get into those like systems that people are already in.
Right. So changing the delivery service system to help achieve penetration, which is really, if you've got a community, you know, and my thinking about that outcome, you know, involves cherry picking that we tend to do. That if there's an intervention that's really hard to deliver, we may tend to use it with people who are on board, who have our same level of health literacy, conceptual similarity to us, who are going to get it. But with a client or a population where it's going to take a lot of explaining, then we may say, oh, that's going to be too hard to make that fit. So we can perpetuate inequity. Heidi, one last comment?
Yeah, I was just going to say, I think a lot of times the effectiveness data behind the thing is not necessarily based on testing in the population experiencing the disparity.
Right.
So going back to the question of, is the thing effective and does the thing perpetuate disparities? And if so, all of these things don't matter because you need to
Go back.
you need to think about the thing.
Yeah. And actually, in one of my very earliest implementation studies, and you know, your thinking is shaped by more likely to be shaped by the obstacles and the failures that you have than the successes. So we were trying to implement a collaborative care model of depression care in a publicly funded state aging services, in-home services for older adults. And, you know, these were isolated, frail, impoverished, depressed individuals. And guess what? Even though our intervention was free, even though we had done task shifting and were delivering it in-home through aides that they knew and trusted, they didn't want it. Now, not everybody, but we had like a refusal rate of like 36%. How can this be? I went back and looked at a couple of the effectiveness trials that reported refusal rates, 33%. So we weren't doing that much worse in taking it to the real world than the investigators had done taking it to the targeted group in a controlled effectiveness trial. So it underscores your point that we need a lot of data from effectiveness tests of the thing. And remember the hybrid one from yesterday? Its main purpose is to test effectiveness, but its secondary aim is to capture as much information as we can about the context, about receptivity, you know, about the time it takes to deliver. We need all that kind of anthropological, observational data, and that needs to be published. You know, it's not just noise in conducting the study. We need to publish that because that feeds into the information we need to develop and test implementation strategies, which are going to boost our success at the implementation level. So I just want to underscore the importance of leveraging data with a hybrid one perspective about testing the thing and exploiting that to help facilitate the development of implementation strategies. And then, of course, thinking about, you know, so what does that tell me about reaching equity? So an even tougher question, foreshadowed by the reflection yesterday and the wrap up, that that Heidi delivered this morning, you know, if we want to achieve acceptability, if we want to improve the acceptability of an intervention to patient, community, service system clientele, to make it more equitable, what kind of strategies could we use? If cost is a barrier for under-resourced service systems or communities, what kind of strategies can we use? Because we will remain at the descriptive level if we simply identify the implementation outcomes that are barriers to achieving equity. Thus far, the literature doesn't offer us a lot in terms of equity-focused strategies and helping us know where to focus those strategies at different phases and at different outcomes in implementation. Now, again, I'm the messenger. You may be getting a headache, but remember that was my charge, to share some new territory, some new ideas, and I don't have the answers to this, but I think these are very important questions if we're going to advance implementation science toward equity beyond equity being a rallying cry. It has to be a focus for our work. Okay, so if that weren't messy enough, talk about chaos, we're going to move to another topic of concern for me, and that is the speed in which we attain implementation outcomes. So some questions, and I'll refer you to a paper that we just published a couple months ago in Global Implementation Research, and applications, yeah. And yeah, I'm the first author on that. Lisa Saldana, who does the SICK to measure. David Chambers is an author, Ross Brownson, Alex Ramsey. We tried to pull together a team of people whose work is directly or indirectly reflecting some awareness of this as a challenge. So we assert that speed is an understudied metric in implementation science, and that all of our design innovations notwithstanding, they equip us to study speed and to expedite our projects. And especially hybrid effectiveness implementation trials are heralded as a tool to help us move more facilely between effectiveness research and implementation research. But there seems to be little evidence that we've not accelerated implementation. And thus we seem very ill-equipped to answer the question, what are the variables, what are the conditions that impact speed of implementation? So I want to go back. I want to pause. Is anyone doing research where you feel that speed matters? Jane, can you give an example?
I was more thinking that partly speed matters because as a researcher you have a finite time. I was just thinking that as a researcher you have a finite amount of time to make an impact.
We do have to get it done. We do have to get it done in the funding period. Let me help you by reframing my question. Where the implementation of a discovery, where speed of that really matters for the target population, here and then in the back.
I work in mental health and corrections, and so sometimes speed doesn't matter depending on sentencing, but we do really care about potentially trauma treatment in people who have smaller sentences, so you can kind of get at that little piece of time before they would return to society. So it's that piece, and then the reentry piece is also timely.
Okay, and we have an example in the back.
Thanks. So one of my areas of research is looking at the implementation of constraint-induced movement therapy for young children with stroke. And the reason I think speed is so important is because you really have such a limited time when the child is growing and their brain is growing so rapidly in the first years of life, and we are missing it. We know this intervention works and nobody's getting it.
Okay, Heidi.
Interventions focused on the postpartum period, especially for patients who only have access to health services for the duration of the pregnancy and the immediate postpartum period.
So all of these are examples where you have a window to intervene. Let's think about how the scientific process affects that. So if we have a new discovery this month, a landmark study or a scoping or systematic review, a consensus panel, a new guideline is issued. These examples have a very short window, or we're going to miss some people. So again, if it's going to take us 17 years to apply this emerging knowledge into real world practice, we're going to lose the opportunity with these in all of these examples. So not only do implementers need to be moving quickly, researchers need to get their job done during the funding period, and the translational process needs to be expedited so that we can more quickly leverage emergent discoveries. So I would suggest that speed always matters, but what we do with it remains a challenge. Speed of implementation is pretty complex, and in our another author is Tom Maddox, the head of the Healthcare Innovation Lab at Washington University. And even within this team of authors, most of whom you know their names, you know their work, we wrestled with, can it be too fast? Can the translational research process be too fast? Now, a public example of that, of course, was vaccine development. And a lot of people who didn't know that we were building on 20 years of DNA and virology work thought that the vaccine was developed too fast. And this became a concern that undergirded the acceptability of the vaccine. How can it be this good? Nobody's ever had it before. They're rolling this out. They're pushing it on us. And I want to wait and see if it's safe. So can there be too fast? Can there be too slow? These are questions that I think we need to capture. But the challenge is that we have very few metrics for actually measuring speed. And we have few models that lay out the variables that likely affect the pace of implementation. And I want to highlight the work of a colleague of ours, Elvin Ging at Washington University, who analyzed the speed at which COVID mitigation policies were analyzed in June of 2000. And June of 2000, we didn't have a vaccine. All we had were mitigation policies. We didn't even have wide-scale testing. I had COVID during that time. There were no tests that I could get in St. Louis. But Elvin leveraged hospitalization data in relation to COVID, the timing of COVID mitigation policies, and simulated and analyzed a massive amount of data and found that if we delayed policy implementation by 1 week, hospitalizations increased from around 2,200 to 8,000. So think of the healthcare cost. Think of the treatment burden. Think of the trauma at that time associated with hospitalization for COVID. More important, deaths increased. There were 482 deaths, but this is the part that he modeled. A 1 week delay would have tripled the death rate. If we delayed 2 weeks in implementing these policies, we saw almost a 600%, we would have seen a 600% increase as to what was actually observed. So, a mentor once told me that every grant proposal needs to put the blood on the tracks. And being kind of gore averse, that's kind of a bloody image for me. But we need to lay out, does it matter? So when you are proposing your research and trying to garner support and participation, if you can show, if you're interested in timeliness of implementation, if you can show how it matters, you're more likely to make a compelling case that your study is urgent. Okay, so here are the authors of this paper. It's called FAST, a framework to assess speed of translation of health innovations. And it's mostly a make the case piece. And we pose the question, does haste make waste? Certainly the kinds of health and social crises that I've illustrated, the reactive nature of our systems. I mean, really, how nimble is public policy? It's not very fast to change policy. And yet we see that lives are at stake with delays. And certainly inequities. We don't want the adversity associated with inequity to persist. We want to rid our communities of inequities. So these all argue for speed. However, there are some yellow light, maybe red light in some case, indicators. Do we move ahead of the evidence? Do we really want to receive treatment that is not yet shown to be effective just because the situation is urgent or pressing? And, this, I think, COVID really exemplified the ultimate case study with this, especially for intensivists who were treating patients in hospitals. They literally did not know what would work. So did they slow, or did they make their best effort and forge on? Again, I'm so grateful that science was working 24/7 as fast as they could behind the scenes. Does the importance and need for stakeholder engagement suggest that we slow down? I commented yesterday that I so rude, R-U-E-D, the fact that we did not have stakeholders at the table to pre-bunk misconceptions about COVID vaccines. I'm not sure that would have slowed the process. It would have kept people on board with the developments that were occurring. But, it does take time to identify the right stakeholders, to bring them to the table, to engage in processes to capture their perspectives, and then to modify our research procedures and the thing and the strategy based on their feedback? Do human-centered designs necessarily indicate the need to take it a bit more slowly? I don't know. So I'm going to challenge you in our interactive session to think about, does trying to achieve acceptability to key stakeholders, what slows the attainment of acceptability and what speeds it up? Can we reach these implementation outcomes more quickly? Fidelity, what slows our equipping frontline providers to deliver the thing with fidelity? Do we have clumsy or time-intensive training models? Can we be more efficient? Can we be more parsimonious? And what might speed these outcomes up? And then who cares about stakeholders and why? And we have a table in our paper with some not hypotheses, but conjectures about which of our stakeholders, administrators, payers, intervention developers, implementers, communities, who cares about speed, and how and why does speed matter to them? So some of the factors that we think may influence speed are features of the innovation itself. The thing. Is the thing complicated? Is the thing streamlined? Does the thing involve learning processes that you can't do overnight? Is the thing multi-packaged, multi-component? Adopter characteristics, from Rogers' diffusion of innovation, we have the notion of early adopters and the unfortunate term he used, the laggards. So is that baked into our personalities in terms of our risk or our eagerness for the novelty? So how, if an organization is new at implementing a program, is that going to slow things up? Features of the context, there are headwinds blowing at us, multiple priorities going on at once. We can't tolerate this change because these 3 changes have been foisted upon us. So what's going on in the context? And then similar to the thing, the implementation strategies. How streamlined can we make them? Are they parsimonious and efficient? So some of the challenges that we uncovered in studying speed are very few studies actually report when they're measuring speed, what phase, what they're trying to attain, what observation periods make sense, and how do we measure speed. And we put forth some examples of possible metrics, either number of months, slopes, visual depictions, graphs, and certainly who can do what. Where implementation science is a team science, and we build on organizational, social science researchers, behavioral researchers, and we need, mechanisms of change are not very thoroughly understood. And if we understood mechanisms of change more thoroughly, we might have a sense of the complexity of the change and the nature of the change. And implementation researchers, I wished, and I mentioned this yesterday, that we would accrue repositories, databases of strategies. What were they used for? What was the strategy? How long did it take? And what outcome did it attain? We need, we can't go forward reinventing the wheel or searching the literature on our own. And guidelines consolidate the evidence around interventions. I know of nothing, and please correct me, in terms of consolidated go-to sites for implementation strategies that are appropriate and effective for varying settings and contexts. And think how much better we would have been positioned if we knew how long it takes to get buy-in to vaccines, to get people to change behavior such as social distancing. So I leave you with some questions. Can FAST lead to sustainable change? The award-winning Tony Award actor Andre DeShield says the fastest way to get where you are going is slow. Does that apply to implementation science? Can we be fast and be satisfied with the process? Does fast last? How fast is best? Is it a Goldilocks dilemma? Should we be moving not too slow, not too fast, but just right? And what is just right? And finally, I leave you with some thoughts about designs, and I look forward to hearing more from Aaron. Alex led a paper of some of the same members of this team, designing for accelerated translation. And I encourage you to take a look at that in Journal of Clinical and Translational Science. And I thank you for hearing all the things I don't know, but that I'm wondering about. Do we have questions? How much time do we have? Okay, have about 10 minutes for questions. Didn't I set the stage well for saying I don't have the answer? You can ask me, right? You can answer among yourselves. Yes, Jane.
My first question, and I might just start by asking one, but I feel like when we talk about speed, I guess I'm not quite sure I understand speed towards attainment of what. Because, for example, if you said 100% of the people who should get an intervention get it, then speed towards that. I mean, I'm trying to understand what's the benchmark that we're striving for, because it seems like the barriers depend on how we define the benchmark.
We really wrestled in the paper, and we laid out a distinction that we ourselves were getting caught up in by failing to distinguish. And that's the speed of the production of research and the speed of implementation once that research is developed. And we distinguished those two because we thought they both merit attention. And that, in fact, one of the slides toward the end that I went through pretty fast asked, what is the appropriate measurement observation window? One of the problems with the 17 years paper is that I think the clock started ticking with maybe the preparation of a grant proposal. And the 17 years included developing the hypotheses, getting the funding, launching the trial, collecting the data, analyzing the data, and then moving it into real-world care, not very clearly defined. Now, that may seem like a ridiculous window, but let's think of something truly novel, like COVID. People did have to start writing grant proposals. We're not going to get the results of research about, for instance, long COVID. When did people become aware of long COVID? Pretty far into the initial stages of the pandemic. Now, NIH had a fast track for grant proposals around this. But nonetheless, that whole period of time from when we realize there's a problem and we begin to formulate research questions. Then we develop a design, then we submit a proposal, then it gets reviewed, then we launch it. You know, so that very long window that is reflected in the 17 years. We can't say, well, you know, they were still at constructive block. We're interested in the time from someone coming into our healthcare setting to their getting better care. That's often the observation window that I'm dealing with. But for researchers or for translational research, such as our CTSA program support, we do need to consider this very long process, or I should say multi-phase process. We think, how can we shorten it? So that my answer to that is it depends. And my challenge to the field is let's start defining and articulating some meaningful observation periods and some meaningful targets. Time to what? Right now, you know, we don't see much in the literature around measuring time, around even defining or including a temporal dimension in research studies. So I probably didn't answer because.
Well, I think what I'm understanding is measuring time is a really important dimension to measure. And when you're going to measure it, you better define what you're measuring.
Exactly. Yeah. And how much, and you know, I'm just saying, how much better equipped we would be if we had that very basic descriptive information.
Mm-hmm.
Thank you so much for your talk this morning. It's been very thought-provoking. I'm curious, could you please comment on the interaction between two of your core areas this morning, which is health equity and speed? And sometimes those things can conflict or be troublesome, and working in particular with trainees, how to support them and building the community connections they need to be doing the work, which can take the time. So I'd just be really interested in your reflections on the connections between those two things. Thank you.
Thanks for a really great question. And yes. You know, I think that those of us who mentor people toward in their research career development, we all know how short the time to tenure is. And tenure does matter. You leave if you don't get it. You have to start your career somewhere else. And yet those of us who are passionate about engaged research, I mean, how many times have we argued in a tenure review committee meeting or faculty level discussion, but stakeholder engaged research takes longer? And how many junior faculty do we have to think with about whether they have time in their short trajectories in their research process and the milestones they have to meet for certain kinds of research? And, you know, that's really detrimental on, you know, there's no way around that. It's a lack of fit between the processes that people want to use for their research and their context, because there's a timeline in their context. And we believe, I hope there's some evidence out there, that engaged research, inclusive approaches, human-centered, responsive study protocols is really important in our efforts to learn how to achieve equity. Now, I don't know whether there's evidence about that. The engaged research does take longer. Seems to make sense. But it's unfortunate. So all I can say in response is you have a very important observation. You're raising an issue of concern. It's very real, and it may be up to design experts to, there's now rapid ethnographic approaches. I think, and our fast paper does point people to some research design accelerator paths. We think the hybrid, especially if we exploit each stage of research to learn what we need to do for the next stage of research. But it's a misstep. Thank you. All right. Thank you for the time taking. I've just had the word that we're out of time and time to move on.